group. My name is Dr. Anouk Desi, and I will be chairing the meeting today. This meeting is not being broadcast live, but is being recorded, and it will be available to watch on the CCG's website after the meeting. Furthermore, members of the public have been able to join the meeting, which was advertised widely, and to watch this meeting live. I'd be grateful if members of the public can turn off their microphones and their cameras during the meeting. There is an opportunity for members of the public who are watching the meeting to ask live questions about any items on the agenda, or to ask for clarification if they're uncertain of anything that's being discussed during the meeting. This can be done by raising your hand at the appropriate slot during the meeting or at the end of the meeting to ask questions, either using the technology of raising your questions or by physically raising your hand if your camera is switched on. Members of the public can also raise questions by email during the meeting by emailing nwccg.contactus@nhs.net. If the question relates to an agenda item, then this will be read out at the end of the meeting. The governing body will either answer the question or defer the answer, in which case a response will be prepared in writing for the requester within 7 days of the meeting, and the answer will also be set out on the CCG website. The governing body meeting is a meeting of the CCG which we hold in public, but it is not a public meeting. Accordingly, any questions which are not related to agenda items will be answered and displayed on the website, but will not be read out during the meeting. By way of introduction, I'd like to welcome to the meeting Ed Garrett, who is our accountable officer for the CCG, newly taken up that role until April, currently planned. Although, as you'll hear later, we're not quite sure of timescales in terms of the CCG being discontinued. There's been an extension on that. Ed comes with a considerable experience as an accountable officer for CCGs in Suffolk and North East Essex. So I'd like to welcome him to the meeting, and he'll be taking part in the meeting. I'd also like to welcome Tracy Bleakley to the meeting. Tracy is Chief Executive Designate for the NHS Norfolk and Waveney Integrated Care Board, which will take over from the CCG many of the functions and have additional functions when the CCG finishes. So I'd like to welcome Tracy to the meeting. And before we start the main body of the meeting, I would like to both say personal thanks, but also on behalf of the governing body, I'd like to say a thank you to Melanie Craig, who finished as accountable officer at the end of December. I worked very closely with Melanie for a number of years, and specifically in the last 2 years since I became chair of Norfolk and Waveney CCG, and she was accountable officer. I've got a huge amount of respect for Melanie, and she achieved an enormous amount during her time in Norfolk, working in Norfolk and Waveney, but specifically in our CCG when I worked with her. And I'd particularly like to thank Melanie for all the hard work and effort that she put in at a particularly difficult time. The CCG started its operation at the very time that the pandemic struck. So we had a whole new range of unforeseen challenges, and she really stepped up to the plate in terms of dealing with the pandemic, the pressures of uncertainty about services, and particularly more latterly in being central to the vaccination programme, which as a CCG we've achieved, I think, hugely successfully, and in large part that's due to her commitment and work, and I've seen that at first hand. So I wish her, and I'm sure that you would want to do so as well, very well in the new role that she's taken up within NHS England. Okay, so we'll now start the meeting. I haven't had any apologies, and I think we're certainly quorate, and I think we've got everybody that we were expecting. Item 3 is declarations of interest. So just a reminder, first of all, that that we keep a register and to make sure that it's up to date and accurate. And if there are issues which we are discussing today where you feel that there may be or may be a perception that there is a conflict, please can you let me know either now or at the time. And I think we've got a couple of points that people want to raise in relation to this so firstly Robert and then Kathy.
Yes, thank you, Chair. I'd like to record the fact that my wife is a vaccinator working as part of the National Vaccination Programme, and we have the update on the vaccination programme later on the agenda. Thank you.
And Kathy?
Thanks, Chair. The Register of Interest notes that I work as a nurse reservist carrying out vaccinations across Norfolk. It's just to update the governing body that the reservists have now been deployed to Norfolk First Support, carrying out social care to facilitate discharge across Norfolk, and I'm taking my first shift tomorrow night. Thank you. Okay,
well, thank you for informing us and very good wishes for your first shift tomorrow. Okay, so let's move on to item 4, which is to approve the minutes from the last part 1 public meeting that we held, and that was on the 23rd of November 2021. So can I take there's the whole document there in terms of accuracy. Are there any points people want to raise first of all? And I'll, unless asked otherwise, I'll take the whole document as a whole. No? And John?
Yeah, it's just one, excuse me, one thing on section 10, which is page 10 of the minutes, where we talked about age-related hearing loss. The second paragraph says the current contract in Central Norwich. That should say Central Norfolk.
Okay, thanks, John. So we'll amend that to say Central Norfolk rather than as it does Norwich. Okay. Any other items of accuracy? Okay. So with that amendment, we'll approve those minutes. And are there any matters arising from that last meeting which we're not covering otherwise on the agenda? Okay, thank you. So we'll move to item 5, which is the action log and any matters arising from that. So I think that was sent as part of on the PDF, but it might not have been sent with the individual files on the minutes. I'm just getting that up, but I'm having some technical difficulty in finding the file now.
A neutral update on the first row, if that's okay.
Yes, please.
So we have met to discuss the equality impact assessments for the clinical threshold recommendations. Obviously, of 80 or 90 thresholds. So what we've decided to do is to group them into logical groupings such as gynecology, dermatology, cosmetic procedures, orthopedics, and so on. And so we will produce a equality impact assessment for each individual group of policies, and obviously take that through our clinical policies development group. So that work is in hand, and obviously the GPs and myself on the clinical policies development group will complete that piece of work through that group. Thank you.
Okay, thanks for that update, Mark. And that now found the paper. So in terms of the open actions, those staff and wellbeing, which I think is the March was a meeting target to have a report addressing staff wellbeing. So I guess that's still in progress. No, any further? Yep. Hilary? Yep. Okay. And then I think the only other 2 items are 27 and 28, which Kath, do you want to just give us an update on those?
Yeah, absolutely. So I've provided an update which will be published on the website about the crisis cafes, but in essence 3 are in place and 2 will be open by April. But that detail will be on the website, so I would recommend that item be closed. And in terms of number 28, I have contacted Richard, who I think has joined the meeting now. A bit of a delay because I've been involved in the urgent and emergency care pressures. But Richard, I'd be very happy to meet up with you and talk through anything at some point if you want to get back to me. Thank you.
Okay. I mean, bearing in mind that that was Richard. I mean, Richard, do you want to come back on that at all? Because I know that was an issue that you raised. I sprung that on you. There'll be an opportunity at the end as well to ask questions if you wish. Okay. So let's move on then to item 6, which is to receive the Chief Officer update. So I'll hand over to Ed Garrett.
Thank you, Chair, and thank you so much for the welcome at the start of the meeting. I have to say I felt extremely welcome in Norfolk and Waveney from day one, and I've really felt part of the family from the get-go, which has been excellent. I just wanted to say how impressed I've been with the CCG and its staff, and indeed the collegiate working across the system in Norfolk and Waveney. I think it's a system with great people and great potential. I'm really excited to be playing a very small role in the system. I think Tracy's appointment is excellent, and she will drive the system forward in the right way. And like you, I'd like just to pay tribute to Melanie, who I've worked very closely with over a decade, in fact, in many different roles. And we'll be working closely together in the future, I'm sure. And she's leaves a fantastic legacy, I feel, in the CCG of everything that she's delivered and contributed to and led. So thank you very much to Melanie. The 3 things I'd just pick out of the paper, which you'll have read, are as follows. So I think since the governing body last met, there's been a huge amount of operational activity within the system. And on the 12th of December, the NHS was put on a level 4 incident by NHS England, which effectively meant we were under national directions in response to the spread of the Omicron virus. One of the major tasks that all systems were asked to do was to roll out the vaccination booster programme as quickly as possible during December, and Norfolk and Waveney delivered over 200,000 jabs between the 12th of December and the end of the month, which is just a phenomenal total, and has been absolutely not only the best performer now in the region, but Timed has been right at the top nationally too, in terms of the pace and the volume of the vaccination programme. What's really impressive too is the work on inequalities in that programme too. And I know that will be touched upon later, but I think it's fantastic that both, if you like, the many and the few have been supported and protected so well, which is great. Allied to the vaccination programme, there's been a lot of work on coping with operational resilience and surge planning, and every system has been under significant pressure, including ours. And I think what this has really prompted and stimulated is some extraordinary teamwork across the NHS, local government, the voluntary sector, all partners, to keep the show on the road and to keep services safe. And I think that's been done very effectively under significant pressure in Norfolk and Waveney, and we'll hear from Kath later, but some absolutely outstanding leadership from many people in the system during the last few weeks since the governing body previously met. 2 other things I wanted to draw out is one is the integrated care system legislation, which the Chair referenced at the start. So there's been a delay to the passing of that legislation, which means that CCGs will continue at least and through to July, with integrated care boards likely to launch as statutory bodies from that time. I understand the ambition is integrated care boards will start meeting in shadow from April. So there's a lot of work to do between now and April to recruit to boards and get the governance in place. But I'm sure that will be what will be delivered. Allied to that, there is a white paper on integrated care being worked through nationally, and we wait to see what that says. But my anticipation is it will be putting an emphasis upon place-based working. And that's something I know that Tracy is very passionate about, as is a lot of people in the system, about how we build up very strong places around our communities and integrated care at a kind of community neighbourhood place level. So that would be a big strategic focus, I'm sure, in the future. The final thing I just wanted to reference is that the National Staff Survey is starting to be shared with embargoed copies. We're not able to share that in the public as yet, but I know from seeing an early version of it, it's some very encouraging results for the CCG in terms of how we're supporting and developing our staff. So very well done to Anna and all of the line managers within the CCG and staff for those results. And that was really my update. Thank you, Anoop.
Okay, thanks very much, Ed, for that report. Any questions or comments from governing body members? Okay, so thanks again, Ed. So let's move on to the kind of what is the main section dealing with our responsibilities in terms of a commissioner within the commissioner within the system. So item 7 is an update on current operational pressures, and I'm going to ask Kath, I think, is preparing to talk to that. But before we do that, Kathy, you've got your hand up.
Yes, I'm sorry, my network seems to be crashing. I'm probably going to have to sign out and try and log in on my neighbour's network, so excuse me just for a minute, sorry.
Okay. So over to you, Kath.
Thank you so much. There are some slides that we've pulled together, but just to say that there's a slightly updated version, simply with a bit more recent data, so it'd be more useful for the discussion, but thank you so much. In terms of where we are in relation to our urgent and emergency care pressures, we declared on the 30th of December that Norfolk and Waveney as a whole system was in a level 2 critical incident, which means that it would be managed at a local level. And it was very current in the national media. And what we noticed was actually mostly across the country, it was single organisations declaring critical incident. And to my understanding, we were the first and only whole system that declared a critical incident. And on the basis of that the focus needs to be on saving lives and preventing harm, and no single organisation could actually make a difference. It was completely reliant on a whole system approach to the risk and challenge that we experienced. Another interesting bit of information to share with the board is, as of yesterday, we have 160 people in hospital with COVID, but there are none in intensive care. And that compares to 800 in hospital this time last year, and 60 people in intensive care. So significantly different. And the reason I'd make that point is to very much set out the importance and the success of the vaccination programme in Norfolk and Waveney, for which we truly believe has made that big difference to have such positive impact in ensuring people are not hospitalised. And in fact, what we're seeing is in most cases, people happen to test positive when they're in hospital, as opposed to being admitted with cause associated with being COVID positive. So that's really positive. But what I will say is the way in which the system has worked together through the critical incident management has been exemplary and has resulted in huge improvements. We identified four system risks that were essentially a real reason why we entered into critical incident, and that was in relation to the clinical risk for patients associated with delayed ambulance response times. There were so many ambulances stuck outside A&E departments, and it meant that people were not getting access to an emergency ambulance when they actually needed it, which was resulting in harm to individuals. That was exacerbated by poor hospital flow, which resulted in restricted bed availability and very high occupancy levels, further exacerbated by lost capacity both in the hospitals but also in the community, including care homes, as a result of not just COVID causes regarding infection control challenges and closed wards, but also a huge number of care homes affected and closed to admissions. And then fourthly, very high workforce absence rates associated with people being either COVID positive or coming into contact until they had a negative PCR with people who were COVID positive. So we set up the critical incident with a pillar structure and identified opportunities for quick wins and prioritisation across the system, including identification of workforce to support be redeployed into the services, and identifying additional capacity both within hospital settings and outside of hospital settings. And we were asked to plan and put in place surge and super surge capacity by NHS England, some of which is in place and some of which is still being planned, such as the care hotel, which some of you will have heard about through the CCG comms and the local media. But so there is still capacity coming online, which is very exciting. In terms of discharge being probably our biggest challenge, so a huge amount of work in place and underway in relation to improving discharge, which yes includes increasing the level of capacity to support discharge. But last week we undertook a whole system multi-agency discharge event, which essentially became the single priority across the whole of Norfolk and Waveney Health and Care, which was really quite exciting, and identified opportunities and focus and priority to improve flow through the hospital, increase capacity and support decision making for discharge. And as a result of all of the learning and finding from the NAID event, there will be a redesign event in place, put in place, and that will be held on the 2nd of February. In relation to the patients, sometimes you will have heard in the past people being referred to as medically fit for discharge. The new terminology is people that don't have a criteria to reside, and there is data available in the refreshed slide pack, which is now available to you all, setting out across the acutes collectively and the community trust collectively, but then also by single acute hospital, the position in relation to the number of patients that don't have criteria to reside, based upon a required improvement by the 31st of January by 30% at a minimum, and actually with an ambition of achieving 50%. We have seen improvements in the acute providers, in particular the Queen Elizabeth. It's been really quite remarkable, the level, and they have already achieved the 30% reduction, and NCH&C also within their community hospital beds have achieved the 30% reduction, but we continue to push to improve to achieve the 50% reduction. And then finally, in terms of our challenges and risks, I would say three collectively. One is workforce, with regard to competing priorities, loss of staff through absence due to isolation of sickness, but also we have a tired workforce that have worked solidly for the last almost 2 years, or more than 2 years if you count the winter prior to really COVID taking effect. And Anna is really, leading the whole workforce programme on behalf of the whole ICS. Social care capacity. So it's fair to say the social care market is really rather fragile and a huge risk to patient flow. And it's really important that we maintain our position with home first being a principle, that as many people go home as possible, or if they go via another route, it is on the direction to going home, and that we do not end up having people living for the rest of their lives in long-term care, which could have been avoided. And of course, we need to manage infection control in relation to COVID, but also the challenges that we're seeing with regard to norovirus as well. So the next steps is focusing on discharge, continued messaging out to staff and the public, really focusing on how we maximise the availability and utilisation of the workforce, and a real focus on staff wellbeing across the system, and a plan to de-escalate from the critical incident and work towards recovery, not just from the last 2 months, but also from the last 2 years. So I'll stop there, Chair. I'm happy to take any questions.
Thanks, Kath, for that excellent report. Tracy.
Yeah, thank you, Kath. That's a really comprehensive update, and it's really good to hear how well the systems come together and work collaboratively to kind of solve some of the problems and work together really to ensure that, you know, services are continued for patients. So, I mean, you mentioned the challenges of workforce going forwards, and clearly that will be, you know, a real challenge. So I do wonder, are there any kind of real touch points at the moment where you're most worried about the workforce? Any kind of key areas, particularly, be they the hospital or in the community, or certainly for domiciliary care? So any real areas of concern? Thinking about the impact of kind of, you know, people requiring to work to have a vaccination as well, that how that might potentially impact on the workforce. And then my second question is in respect of clearly things are really very kind of concerning in that latter part of the year, and did we experience any kind of significant harms for patients, and any real feedback from families particularly about their experience of any harm? So be interested to know, you know, if there's anything at this point in time. Might be a bit early, but just be interested to know that.
Thank you, Tracy. So I think for me, if I make this, if I say this on the premise that actually across the whole system there are real pressures with regard to workforce on a daily basis, but the two that stand out to me personally, but maybe Anna may want to come in on this as well, relates to domiciliary care. So the social care workforce, particularly in the domiciliary care market, is a real challenge, and some of the schemes and surge capacity that we've been planning has been as a result of the challenges with that domiciliary care market. So NFS, which Kathy referred to earlier, where the reservists are being deployed into NFS, is a service that is more of a care-based approach, but with backup from therapy, so a health backup. And they are sitting on a huge caseload of people who should have progressed out of the NFS into a standard domiciliary care market, and they haven't been able to, so it's caused a backflow. So for me, that's the one of the two areas that I particularly wanted to focus on, and the second being mental health. So the mental health services are under huge pressure, increasing demand on their services, and a combination of the roots, the common causes of sickness absence, but overlaid by demand and pressure. I think that is a real hot spot within our area, and NSFT are mobilising, deploying staff accordingly, but I think it was just important to raise the issue of concern in that area. And I'll come back to your other question. I don't know if Anna, you wanted to come in with anything to do with workforce?
Thanks, Kath. So I would agree, social care has been under significant pressure, particularly domiciliary care, and we need to work differently, to have a look at different solutions, because we've got some areas where we're completely lacking in workforce for domiciliary care. I think the Ambulance Trust, actually, over the winter period, they were really hit with COVID absence. Not to say the rest of the services weren't, but they had some significant shortfalls, which meant they had to work differently. We do carry some large vacancies, as well as having really high sickness over the winter period. So that really did put pressure on all services. We're lucky that we've got the reservists, so once they've finished with vaccinations, we could sort of divert them to some of our hospital wards in need. But of course, all of our services were working really sort of below ideal levels from time to time.
Thank you. And in relation to the harm and experience, so we had to, particularly since the end of December, work to a system principle of saving lives and preventing harm. And what that has meant, that there were incidents as a result of the system pressures, such as delays in ambulance arrivals to people's houses, and we are working with trusts in order to establish what the collective level of incidence and harm has been. But what I would also say is, on the principle of saving lives and prevented harm, that meant that patient experience and the overall concept of quality had to take a step back. So a good example of that was, in order to improve flow through the emergency departments at the NNN, and make sure those ambulances were released to go out into the community and ensure improved safety, they then made the decision, with the support of the system, to put a seventh bed or even an eighth bed in a bay that was suitable for 6 patients. That in itself increases the it reduces the patient experience, the privacy, the dignity, but again, it's that balance of decisions. So there will be continued feedback and experiences that we or partners in our system receive as a result of some of those decisions that we made. But the strength in our system is we knew we were having to make some unpalatable decisions, and as a system we supported each other and documented the decisions that were made as part of a decision log, on the basis that we knew we were sometimes having to make the least worst decision at that time to try and keep people as safe as was possible.
No, thank you both. That's really helpful and really comprehensive.
Thank you.
Thank you for that. And to Anna as well. Mark.
Thank you, Chair. Kath, thank you very much for the slides and the presentation, really helpful. I think you've almost answered my question, actually. I was going to ask whether you had any concerns about staffing issues around the surge and super surge bed capacity, but I think I heard you say not, that it's predicated on our ability to be able to staff it fully.
Yeah, absolutely. So there is capacity that's available to be used if we could mobilise the staff. So it's that daily balance of, do we need it, and is the risk of opening and the risk of not opening it, where does the balance of risk lie? So that's a dynamic decision making process that we have in place. But what we've also done as part of our surge and super surge planning is look for those other options, which would mean it draws new staff into the Norfolk and Waveney system, such as the care hotel. So that will be a 15-bedded service, which we will pilot, test and evaluate, but the care is not needing to be, the care workforce don't need to be found from within the existing workforce. They will be bringing it in from elsewhere in the country. So that's where we've also had to apply that creative approach.
Thank you very much.
Thank you both. Any other questions or comments on that report on system pressures? Okay, well, thanks very much, Kath, for the report and for those comprehensive answers to those questions raised by Tracy and Mark. Let's move on to item 8, which I mean, a lot of the themes that you've mentioned in the system pressures relate to COVID and the vaccination programme. Is something that we've covered every time, and I think, Mark, you're going to give us the update on vaccination programme on this occasion.
Thank you, Chair. I'm just giving the report on behalf of my colleague Howard Martin, who's the lead director for vaccinations in Norfolk and Waveney. So I'll take the report as read, Chair. Just to signpost the major sections of the report, 60 to 66 on the agenda pack is the overview of the various statistics in which we're currently doing well compared to regional colleagues in the uptake of the vaccine. Pages 67 to 72 gives the breakdown by geography and some of the locations. 73 to 75 is the statistics in relation to the vulnerable groups. 76 to 78 is the information regarding 5 to 11-year-olds who, as members may know, were recently announced as being members of the vaccination programme just before Christmas. 82 to 84 are some of the policy changes which have taken place since the last meeting, and 86 to 89 is the communication plans and materials which are going out and being used in order to boost the vaccination programme. So very happy to take the paper as read and answer any questions on it. Thank you, Chair.
Okay, so any questions or comments on that report on where we are with the vaccination programme? No. And I think some of the points have already been made about not just the success of the uptake that we've managed to deliver, but what is clearly the effect of that in terms of the pressures that have then come to bear on the system when we've had the highest rates of infection that we've had for since last year, without, thankfully, that converting into admissions and serious illness. And it's good to see that geographical spread, and obviously, not it is across the whole area. But I would just point out that North is doing particularly well, and I just happen to practice in that area as well. But that's just totally coincidence. Okay, so Rob, you're going to tell me off for saying that, are you?
No, not at all, Chair, not at all. Take credit where it's due. I was going to mention, Chair, we've been receiving regular updates as governing body members via email, and I found that very helpful, and I think that's helping us track progress. So we're seeing the results on an ongoing basis, and we've got the opportunity to feedback regularly, and we're having regular updates from the executive team as well. Thank you.
Okay, thanks. Claire?
So Rob's not going to tell you off, but I will. As someone who's seen inequality group, I just wanted to say a thank you to everyone who has worked tirelessly, really, to address vaccine uptake amongst people who find it more difficult to access these. A multitude of different reasons. Team have been doing a huge amount of work on the call, and I'd like to say thank you to Tracy too, because I know many and an awful lot to make a difference to those for access to vaccines generally more difficult. And I think the system deserves huge credit, and Howard Martin as well for leading the team through that piece of work.
No, thanks, Claire, and I'm sure we'd all join in acknowledging that, and I think particularly thanks to the individuals responsible, including Tracy, in the leadership that she's shown in that area, and I think the reason that we've managed to achieve those high uptake rates is because of reaching out to those communities, because actually most people take up the offer and get vaccinated. It's that last few percentage that are the most difficult to reach, and I think that's where the efforts have to be acknowledged, because those are the most difficult ones, and actually paradoxically often the ones that benefit most from being vaccinated, because they're in environments where actually they're more susceptible, but also their health needs are such that they're going to be more susceptible personally as well as the environment that they're in. So certainly acknowledge that. Any other comments or questions on the vaccination update? No. Okay, thank you for that. And just to reiterate, thanks for Howard and the team on the enormous amount of effort I know that they've been putting into this. Thank you. So item 9 is it's a standing item that we have every month to review and approve recommendations that have gone through the subcommittees for meeting clinical thresholds. So Mark, I know the papers have gone out. Do you want to just outline what we're asking the governing body to approve today?
Thank you, Chair. So I'm asking governing body to approve 5 policies which are unchanged from previously, and there's also a new policy in relation to hydrotherapy, for which there is a pool at the Norfolk and Norwich. We've been asked for a commissioning policy on this, and so we've included it in this month's pack for approval. Thank you, Chair.
Got myself on mute then. So first of all, any questions on the policies themselves in terms of what we're asking you to approve? So no changes, they are continuation of policies that are already in place. So if there aren't any questions, can I ask you to approve those policies? Okay, I'll take that as unanimous. Thank you. And then item 10, similarly, are to approve recommendations made from the Drugs and Therapeutics Committee. And I think we've got Michael Dennis here today to talk to that item. Is that right? Yes. Welcome, Michael.
Oh, hello. Thank you, Anoop. So Norfolk and Waveney tag, and subsequent Drug and Therapeutics Committee. This is our standard paper to talk through any business cases or NICE technology appraisals and pathways relating to drugs and the local decisioning thereof on any costs. So the papers go to tag for a clinical recommendation, just by way of background, and then go to Drug and Therapeutics Group for a commissioning recommendation, and they come here for ratification. Nothing specific to highlight, except I would I will highlight inclisiran, which is currently still being worked through, and in terms of a local pathway for that drug, there's a little bit of controversy around the introduction and commissioning of this drug nationally, and we're just working on a version of a lipid pathway, which our local lipid specialist is happier with, and perhaps putting more evidence-based drugs above it. The drug will still be available for those patients who need it, quite clearly. But other drugs perhaps have more evidence base, and this has been highlighted to GPs via the BMA and the Royal College of GPs recently in a letter pointing out the lack of perhaps evidence of it. And the need to engage with patients, if you wish to use this drug, that you might need to explain there are other drugs which might better suit them rather than this injection. I'm happy to take questions, comments.
Okay. Any questions or comments for Michael? No? Okay. So in that case, we're asked to approve those kind of recommendations which have been made and gone through the Therapeutics Committee. So can I ask you to approve? Okay, great. Thanks.
Okay, many thanks.
Thank you, Michael.
Thanks, everybody. Great.
So we're running half an hour or so ahead of time, which I'm happy with. We've penciled in a break, and I would suggest we continue without that now and see where we end up. So I'm getting some nods. So let's move on to item 12 then, which is the financial report for month 9, which John Ingham, our finance director, will talk to that item. So John, over to you.
Okay, thank you, Anoop. So hopefully the paper is clear, but just a couple of headlines. It's the position as of month 9, as at the end of December, and just a reminder, we're still under the interim financial regime that's been in place in the pandemic, whereby there's been additional funding coming through to systems to make sure that costs are met effectively within systems on a temporary basis. So the headlines are positive. The CCG is breaking even year to date, and we're forecasting delivery of break even at the end of the year, but that positive picture hides some underlying pressures that we've got that are pulled out in the paper around, in particular, continuing healthcare and GP prescribing, where volume and in particular price rises are coming through much higher than some of the uplifts that we're receiving nationally. And that's particularly the case in continuing healthcare, when we're clearly trying to respond to market pressures in the domiciliary care market and care home market that we've heard about earlier in the meeting. So the fact we're able to balance this year despite those pressures is really because we're getting support from system partners who are in an equally kind of favourable position effectively. So we're benefiting as an organisation from £5 million worth of support that's coming through from providers. And the other aspect that helps with is the fact that we did have an ambitious efficiency programme to try to deliver this year, to deliver our balanced position, because of the need for individuals within the organisation to focus quite rightly on the vaccination campaign and on the delivery of critical services around urgent care. It's not been possible to pursue those efficiencies at the same rate. So hence the need for some of that support from system partners. A couple of other points to note. One is that we are on track to deliver the mental health investment standard, which is clearly really critical that we deliver at all times to make sure that our growth in mental health spend is at least as much as the growth in our allocation. And also the Finance Committee has been through the paper here last week, so has had the chance to scrutinise. Final comment I'd make, so as I said, there will be no financial issues that we're expecting this year in terms of delivering our statutory duty, and money won't be a barrier to delivering any of the urgent care priorities that we've heard about earlier in this meeting. We'll make sure that if there's things that need money to help facilitate them and can obviously deliver value for money within that, we'll look to ensure that we support that. But next year is going to be much more challenging. And I know we always say that in the finance community, it's always going to be much harder in the next year, but that is absolutely true. The situation nationally is that we're returning to something that's more similar to the previous financial regime that we knew before, with some tighter controls really on the funding that's coming through to systems, an expectation of reductions in some of the excess money, if you like, that's come into the NHS over the last year or so. So things are going to get tighter in the coming year, but we'll hear more about that in the March governing body meeting. So I'll very happily answer any questions. I think you're on mute, Anoop.
Thanks, John. And while we're waiting for any questions, and I mean, I think you partly have covered it already in your report, but can I just ask you to just give an indication? You mentioned about next year being tougher in terms of the finances, and partly because of the additional funding that's been provided, this year. But is there some way of kind of quantifying? Because obviously people are concerned about the long waiters and the waiting list having gone up, and that's a group of patients who haven't been treated this year but actually are on the list, and the drive will be to work hard in the coming year, 2 years, 3 years on that list. Have we quantified what that is, but also what the cost will be? Obviously, I know we moved away from payment by results and tariffs, but in terms of the actual cost, that does equate to a risk, doesn't it, in terms of delivery, but also the cost associated with it.
Absolutely. So yes, the two things kind of go hand in hand and help to build up the whole financial position, if you like. So there will be pressures next year in terms of things like the extra money we've had for COVID-related costs is reducing significantly next year. There'll be no funding for hospital discharge and things like that. So pressures on that hand. On the other hand, there's very significant new money coming into the NHS to deal with elective backlogs. So we expect within Norfolk and Waveney to receive somewhere between 40 and 50 million pounds next year, or to be entitled to that if we deliver the activity to support elective recovery. So some very significant additional funding to support that. But there will be pressures on the core business as usual funding as well.
Okay, so that has been factored in, and there are assumptions around what will be available for that. Rob, and then Mark, and then Arden.
Yeah, thank you, Chair, and thanks, John. It's particularly pleasing to hear your report that we're on course for break even this year, given all the uncertainties and pressures that we've had in the last year and more. Just like Anoop, thinking about next year now, and the two areas of particular pressure that you've mentioned in respect of the current year, are we doing some work in those areas to understand what the scope might be to manage those in financial terms going forward?
And the short answer is yes. So a big part of our focus on CCG-led efficiency work, if you like, is looking at continuing healthcare and GP prescribing. And continuing healthcare, we've had some external resource in to support some of the reviews of higher cost packages, which has been positive, and we'll look to do more along those lines. I think where we can get resource in to support the team who are under pressure at the moment. Within GP prescribing, there's a good chunk of work that Mark Lim is leading to understand where there are efficiencies to be gained, both within GP prescribing and looking at prescribing across the system, where there's things that might start in secondary care that could be could have a financial impact, if you like, on primary care, that we might need to encourage our colleagues in secondary care to do differently, if you like. So there's a fair bit of work on that. And also in terms of understanding the market pressures, again, going back to continuing healthcare in particular, trying to work closely with the council, who often have their own view of what the market rates should be. And then clearly we need to make sure that we're following the kind of line set by the council. So looking to work more closely with the council colleagues going forward.
Yeah, thanks, John. That all sounds very good. Thank you.
Okay, thank you. Mark?
Thank you. John, on your first slide, you talk about the full year forecast outturn being a surplus of 9.7 million ahead of planned break even, and that's due to lower expenditure on the part of the providers. What particular type of expenditure is it that they haven't been incurring? Is it largely staffing costs?
I think there's a bit of staffing, Mark, but I think a lot of it is around, it's partly the additional money that came in to support the costs associated with COVID itself and some of the absences that we saw originally, and some of those absences, whilst they're still higher, maybe less than they were originally. But also in particular, it's the fact that they were looking to progress their elective programmes and they've just not been able to progress at the speed as had been hoped in recent months for obvious reasons, because of the urgent care pressures. And so there's quite significant underspends on consumables, for instance, that would be used within procedures. Mm-hmm. And also I think some underspends against some previous assumptions about maybe trying to do extra weekend lists and the like, so where there might have been premium cost for staff. So it's largely around the elective work. And clearly that's despite the best efforts of the providers to try and get through their backlogs as well.
Yeah. Thank you very much.
Okay, and Arden?
Yeah, really good news that we're on course to break even this year, which is quite astonishing given all the pressures you've been under. So very well done to your team, John. In terms of the particular prescribing pressures, I was interested to see the 2.5 million for general practice and wondering whether there's an opportunity here to harness some of the PCN pharmacy support that we have in place now, particularly around issues such as polypharmacy, repeat prescribing, branding and evidence-based medication. And I'm sure there is scope for us to do some work in those areas. I was also interested about the prescribing pressures around anticoagulation and wondering if we were offsetting that against the infrastructure with warfarin prescribing and the previous having to deliver that with, for instance, within the hospital teams, and if that could be offset against some of those increase to wholesale use of DOACs.
Don't know if Mark Lynn wanted to come in there, actually, Chair, because he's closer to these initiatives.
Thank you, John. Thank you, Chair. Thank you, Arden. So, yes, I think the GP prescribing is going to be a significant area of focus for us. So I think there are obviously things that were already in the pipeline in terms of, say, for example, rationalising particular stomas or particular agents as well. But we think there is definitely room for PCN pharmacists to do more in relation to certain switches that they could do in pharmacy. I think the advantage of going through the PCN pharmacists is that it's obviously their own practice which does that, and so compared to, say, getting some people coming in to do that as a locum, then obviously there's not a risk of the patient going back to their doctor and incurring additional time only for that patient to be switched back to what they were originally. We are in the process of launching a campaign in relation to over-the-counter medications. So clearly, if patients go to general practice to get medications which they are able to get over the counter, that obviously increases both the spend from a CCG perspective and also takes up practice time. So we're just using some experience in some previous areas such as North Norfolk and other areas within the region to launch that campaign. And then I think the third main area in the GP prescribing areas, there's still a fair amount of significant variation. If you were to look on year increases between different practices, there's quite a lot of variation between, you would expect all of them to go up roughly the same amount, but that's certainly not the case. And so there's a more detailed piece of work, which is fairly labour intensive in terms of liaising with practice partners who are leads for prescribing to understand that. And we have had good engagement from the majority of them, but that's sort of the third area, which at the moment isn't sort of fully baked into our plans, but we'll deliver going forward. Thank you.
Thanks, Mark.
Okay, thank you. Any other comments? I take it, Mark, that your hand is not up anymore. Okay, well, let's move on and just thank John for the month 9 report, and in particular, I know the amount of work that goes on to balance the books and to meet our statutory targets. So very well done to be reporting that at month 9 at this stage in the year. It's very reassuring. So thank you for your hard work to you and your team, John. Let's move on to item 13 then, which is the governing body assurance framework, to review the framework which sets out the current risks and what the risks that we foresee in the coming months for the CCG. So Karen, do you want to go through particularly any changes in the register within the framework since the last report?
Thank you, Chair. Yes, here's the usual update on the governing body assurance framework. The changes that we've made this time are listed in the paper, so I'll take those as read. The GBAF has been updated by each of the officers with current actions and reviewed by the senior management team as well as the executive team. So basically, I'm happy to take questions, and also officers responsible for risks are also here for any more detailed answers. Thank you, Chair.
Okay, thank you, Karen. So you've got the update. Any comments on its on what's in it, or perhaps what's not in it? Kathy and then Ed.
Thank you, Chair. I had a question about the risks, GBAF risk 13 around staff burnout. Now, we had a good conversation about staffing and the risk to workforce in a previous item. I wondered two things really. First of all, do we know which or how frequently our organisations are working below safe staffing levels? And secondly, I wondered if there was anything more we could do in terms of access to food, drink and rest during shifts, because there has been some national publicity about the dearth of hospitals, particularly providing hot food for their staff at night and these kinds of things. And I know some staff have said to me that they find it almost impossible to get to food or drink during a shift. And I wondered if we had any thoughts on that at all.
I wonder if Anne may be able to help us with that one.
Sorry, did you say me?
Yes.
Yeah, so we know that this winter has been really very challenging, as I mentioned before. Our sickness levels are normally around, for the system, are normally around sort of 4.5 or just under 5 when sickness increases. But we've seen as a system the sickness levels being at 7%, which is very high, and individual trusts being at sort of 10 and 11%. Thankfully, this year staff have come back to work much more quickly after a period of illness. But one of the other things that we do know, and we've seen this across the east of England, is that mental health is the #1 cause of staff sickness at the moment. So we do know the sustained pressures over the last couple of years have really contributed to people's mental health and well-being. So I think we do recognise that right across our system that many staff have been working under pressure, and certainly been working in areas where they've been below ideal levels, or having to have extra patients, particularly in our emergency departments, for example. We've been meeting with our system partners on a regular basis, particularly over the Christmas period. Kath has actually chaired the Gold Calls with Mark, and we've been reviewing staffing at those meetings. I also meet with all of the trust leads on a weekly basis, and we look at the pressures, and we talk about how we can move staff around or try to help in areas of highest need. We do have a collaborative bank now, so we're able to share staff across hospitals. So we're doing lots of things, as well as system-wide recruitment, and we have lots and lots of health and wellbeing initiatives in place. So we've got a lot of good stuff going on, but I totally appreciate what you're saying, that there will be areas where some staff may not be getting the care that they perhaps need at that time. I do know that some of the hospitals are supplying areas with food and drink, but again, I'm sure that there are some gaps there. Kath and I are meeting with the directors of nursing this week, our usual monthly meetings, so we will talk to them and we will find out what more needs to be done. But I'm sure that we're going to see an even bigger increase in our wellbeing initiatives as we move forward. But the good thing is that the sickness levels are starting to reduce now, and we are seeing some fruit from our recruitment campaigns. We've just received our first cohort of international nurses that arrived in January, and we've got cohorts coming each month. And we're doing some really good system-wide recruitment. There is no sort of easy answer to this because we have chronic workforce shortages, but we are working really closely with all of our partners to join up on this effort to really support staff. But yes, I mean, this is an ongoing conversation for us at our monthly HRDs group and our Directors of Nursing group, where we're monitoring this really closely. But we need to do more, I recognise what you're saying, Kathy.
Excellent. Thanks very much, Anna.
Okay, thanks, Anna. Ed?
Yeah, I've probably missed this reading through, but do we need a specific risk around mandatory vaccination, the VCOD programme? I don't know, Anna, whether you wanted just to update on all of the work in that area.
Yes, absolutely. I think we did agree that last week at the exec team meeting. So we'll be putting that together this week. So we have, just to update people, that the mandatory vaccinations are coming in April, and the 3rd of February is the date where staff should have had their first vaccination at the latest. We have a system-wide group, so we've got all of our providers represented, including primary care, on our system-wide group, and we're taking a system approach to support our staff to take up sort of the vaccinations. We are really fortunate that we're doing incredibly well, and that the majority of our staff and our people have taken up the offer for a vaccination, recognising that it does protect themselves and their loved ones and our patients. We know that we've got a small minority of staff who have some specific concerns and who haven't yet taken up the vaccine, and we're working really hard to provide additional one-to-one support from their line managers. Our trade unions are working really closely with us to provide support, and we have some bespoke webinars for people that are worried about religious beliefs, so all faiths, and fertility and pregnancy problems. So we have lots of tools and frequently asked questions. So we're working really hard to make sure that staff have every opportunity to get the information that they need to support them to make the right choice. So yes, we will be articulating a risk, because we completed a sort of a national SITREP last week. So that will be our first chance to see the numbers of staff that are declining vaccinations. So we should get that information in the next couple of days, and that will then help us to sort of articulate that risk a bit more. But yes, I mean, it's a risk for every ICS in the country.
Thank you. And I mean, just to go into that in a little bit more detail, I suppose your answer is very much looking at the system, and when we talk about our staff, it's staff across the system.
Yes.
The organisations have their own responsibility for the staff that they employ, and some of the implications might be for people being able to continue in their roles working within organisations. So is there a sense that you have to also separate those staff that we employ ourselves and for whom we're directly responsible, and that we have responsibilities to check on their status and what it means if they're not vaccinated or if they are vaccinated, as opposed to people working within health and social care?
So we've got a responsibility to report on the staff that we employ, and to take action on to support those people. So that's absolutely the risk that we'll articulate. But there is another risk around the staff that we contract as well, or the staff that actually visit some of those services. Or Serco, for example, that provide estates and catering. So it's a really sort of a huge and complex area. But our main responsibility is to make sure that we have taken care of the staff that we directly employ, to make sure that they have every opportunity to take up the vaccine.
Yeah. Okay. Thank you for clarifying that. Arden?
Thank you. Anna's actually largely answered a lot of the question that I was going to ask, which was around vaccine hesitancy. And I know that there's so much really good work going on to support people who still haven't taken up that offer. and who are, presenting to us in primary care with those fears and concerns. I was going to ask really about when we would have the results of the mapping exercise going on, so we can see where the particular pressure points are likely to be in our organisations, and also around just to understand some of the work that we can undergo as a system to try and retain those people and support them, and then hopefully at some point encourage them to go forward and have that and take up that offer.
Thank you. Shall I respond? All of the organisations collected the data last week, so they will be validating that data, because some people will have responded and provided the evidence for whether they had the vaccine or not. Some have declined to respond, so they need an individual conversation, and some people have confirmed that they don't wish to take the vaccine. So all of that will take a lot of working through for line managers to continue to validate the information. So this week we should get a clear idea after those conversations happened. Where are we now? And we'll continue to work on that data over the next couple of weeks. So we'll have the first. Well, in fact, I think the information will actually be in the public domain this week. But the organisations who submitted the data on Friday will have been then having those conversations with individuals to progress any sort of individual sort of specific concerns. And I've forgotten the last part of your question.
It was just about the initiatives that as a system we can put in place to retain people, so that, to avoid them leaving once we can.
Yeah. So obviously we're hoping that those compassionate conversations with line managers and with other colleagues will influence people. We know that some people have medical exemptions. That's acknowledged. But for those staff that really don't wish to have a vaccination, we will of course look at any opportunity across our system to see whether there's any suitable redeployment that can happen, because our first priority is to keep our staff. We don't want to lose anyone, so we'll try everything possible to redeploy. Ending somebody's career is absolutely the last sort of thing that we want to do, but we may not have a choice in some cases, so we will do everything we can to help people with their choices.
Thank you.
Okay, thank you. Doris?
Thanks, Anoop. On to something slightly different under risk 8, although it's not one of our high risk. I notice in the details within that report, it talks about estate issues within the children and young people eating disorder that is delaying some of the plans, and I just wonder what the impact is in terms of effectiveness of that programme.
Perhaps Kath might be able to help with that one.
Yeah, absolutely. So there's the services for children, young people with eating disorders and adults actually remain under significant pressure, and we put in investment into additional capacity which is coming online, because that's been dependent on recruitment predominantly. So that's it's still a watch and wait in relation to the impact. And we also need to reset actually what we think the ongoing demand will be for children and adults in relation to eating disorders as a result essentially of the last 2 years pandemic. So it is an area of real focus for us, but probably a little bit too early to understand the impact of the additional capacity that we brought online. Does that answer your question, Doris?
I think so. It's probably a watching brief in terms of, I know the system is under pressure, and the last thing we need is things that we can avoid, that we can sort out.
Absolutely. So Arden, was there anything you wanted to add?
I know that the children and young people team are trying to work up a planned estates to deliver a supported eating service, and I know that work is underway, as Kath said, so I think we would hope to have an update for you around that soon.
Okay, thank you. So thanks for those questions and those answers as well. Let's move on then to a report from the committee. So item 14, we're going to start from Kathy the report from the Quality and Performance Committee.
Thank you, Chair. This report covers the December meeting. We stood down the January meeting because it was immediately after Christmas when people were working full pelts. As Kath has already mentioned, the system pressures have given rise to a number of quality issues in the system. So we've attached our quality schedule for information to the governing body. The rest of the report I'm happy to take as read and we'll take any questions. Thank you.
Thank you, Kathy. Any questions for Kathy on her report from the Quality and Performance Committee? No. Yeah, Ed, and then Rob.
This may be warm ground for you, but I was reading today about the continuity of care work in James Paget, which is absolutely fantastic, brilliant. I don't know whether there's a similar picture across all of the provider trusts in Norfolk and Waveney, but I just wanted to highlight what an achievement that is to have 86% of families being supported with continuity of care. That's first class.
Yeah. Thanks, Ed. I'll say a bit and then hand over to Kath. I mean, we monitor the LSMS action plan on a quarterly basis. We've certainly made a note of the excellent work that's happened at the James Paget, but it is monitored across all of the providers. And certainly continuity of care of full pregnant women is closely related to improved quality indicators. So we keep a very close eye on it. Kath, anything additional?
Thank you. What I would say is we are incredibly proud of the Paget, and that hasn't been achieved by accident. That's come as a result of immense work and leadership. And the position across the other two hospitals is not as strong as it is at the James Paget. But one of the opportunities and benefits is for the other parts of the system to learn from the excellence at the James Paget. Kathy is absolutely right. The principles of continuity of care is about improving outcomes, keeping women safer and having better experiences, but also the feedback that we heard a few days ago from Paul Morris, who's their Director of Nursing, and Kirsty Cater, their Head of Midwifery, is as a result of the outstanding outcomes with regard to continuity of carer. They are now at a point where they are over-recruiting to midwives. And so what we've got is other parts of Norfolk and Waveney, and indeed lots of other parts of the country, that are struggling to recruit midwives or retain midwives. And yet the Paget are sucking them in because people want to work in that model and environment. So very much critical to the success of maternity services is to roll out this model as soon as possible. So we're working very closely through our LMNS team in order to understand what the challenges and barriers are with the other two hospitals to the rollout. But thanks for raising that point, Ed. They are doing a brilliant job.
Yeah, if you could send some of those midwives down to Ipswich, that'd be really helpful.
I think I need to send them to the NNM first.
Of course, yeah.
It's all collaboration across the whole area, not just North and Waveney. Rob?
Yes, thank you, Chair, and thank you, Kathy, for a very clear and very comprehensive report on the committee's work. I was particularly pleased to read that the committee's receiving updates on the action plan from the Safeguarding Adults review. That's referenced in paragraph 2.3. Could I ask that if you are seeing any slippage in the action plan, and that's an if, but if you are, can that be reported to governing body through your regular reports to us, please? Because I'm thinking back to the meeting last year when we discussed the original review. We took its findings very, very seriously, and we were all very committed to seeing the action plan fully implemented.
Yes, thank you, Rob. Again, we monitor this on a quarterly basis. And I think as a subset of this, I mean, the item 2.2, we particularly pay a great deal of attention in detail to the monitoring and health checks of the inpatient learning disabled and autism cohort, because that was obviously where Joanna, John and Ben, where they inhabited that cohort. So we're paying a lot of attention, but I would be delighted to raise any outliers with the Audit Committee. Thank you.
That's great. Thanks, Kathy.
Okay. Thank you. Kathy, do you want to come back?
Yeah, just to say that, you know, it is we have prioritised the action plan and the oversight, the clinical oversight of this group of patients above pretty much everything else. And I made my position really clear amongst colleagues when we were looking to identify people we could redeploy into the system to support vaccination and UEC back in December. And I said that I would not compromise the learning disability and autism programme, and that the safe and wellbeing reviews, which is a new approach to the face-to-face review of every single inpatient every 8 weeks, and the scrutiny of care and the admission avoidance work that my team are involved in, would not stop as a result of the emergency pressures, because I didn't think that was appropriate. So just want to assure governing body that in amongst all of the pressures that we've experienced, there are many things we've deprioritised, but absolutely this programme of work and this group of patients is something that we haven't taken off the pedal at all.
Thank you for that. Let's move on to 15, which is a verbal report from Hein, who chairs the Finance Committee.
Thank you, Chair. I think John provided a comprehensive overview under item 12, and we also had a good discussion on some key items around efficiency, system balance. I'd just like to add, we'll hear next month in the Finance Committee on the first look of the plan for next year. As John said, we expect some pressure points, and we'll hear back in the March governing body on that. I'll leave it at that. Happy to take any questions.
Okay, thank you, Hein. So no questions. So we'll move to 16, which is reports on the Primary Care Committee, Commissioning Committee, which Doris chairs. So Doris.
Thank you, Anoop. I take the paper as read. Like the Quality Committee, the January Primary Care Commissioning Committee was stood down because of system pressures. Most of the work, the concentration of the last 3-4 months has been reviewing the locally commissioned service so that we have a new service in place to be up and running from the 1st of April. I just want to thank the team for their work and the LMC for their cooperation as well. It's taken a lot of hard work to get it over the line. It is now out to practice for them to sign up to the various schemes of work. And the other main theme that we looked at is linked to learning disability and healthcare checks, and we're getting more regular reports in terms of uptake of those checks, and it is good to see that there has been progress as well. Happy to take questions.
So, any questions on Doris and the report from the Primary Care Commissioning Committee? Okay. So 17 is the report from the Audit Committee, and which Rob Bennett chairs. Rob.
Yep, thank you again, Chair. Short report on the outputs from the last Audit Committee. Again, I'll take the paper as read. I'm happy to answer any questions. One item I'd like to draw your attention to, and that's in paragraph 7, where I'm reporting that the committee was informed that there were no reported breaches of conflicts of interest.
Okay, thank you. That's very short. Any questions for Rob from the Audit Committee? No. So the final one from the committees is 18 from the clinical executive of the CCG. So Mark, do you want to?
Thank you, Chair. So like some of the other committees, we have stood down a couple of the meetings. But the meetings are recommencing next Tuesday. So in the meetings that have taken place, we've focused on the areas which are listed in the penultimate page of the report, and I'm otherwise happy to take the paper as read and answer any questions. Thank you, Chair.
Thank you. So any questions for Mark on the clinical exec? Okay, so that's the agended items on the for the meeting today, which just leaves item 19, which is questions from the public. And before I ask anyone here for questions, I think we have had, at last count, one question, Karen, that we'd received prior to the meeting, or?
Yes, Chair, we've received one question in advance. We have not received any questions during the meeting via email. If the governing body are happy, we can just share that question on screen so that it is also available for the video. The answer has not been put together yet, but will be sent back to the inquirer directly and also put on our website very shortly. So JD, maybe if you could just share the slide for us.
Yep, so we can see that, I think, now.
Okay. So I don't propose to read through it, Chair, but it is there for a few moments. The board has had it in advance, and as I said, it will be on the website for people to read at their leisure along with the answer shortly. So we can probably take that down, Chair, if people are happy.
Okay, so I mean, I don't know whether anyone wants to make any initial comments, although, as you said, Karen will respond in detail, and the answer will be reported on the website. Kath, did you want to come in to?
Yeah, I just wanted to say that it's quite a detailed question, so we'll rely, in order to give a decent answer, it just relies on a bit of time, and I will be asking my team to look into this and make sure then we have a decent response that we can publish and respond to.
Yeah, I think that's appropriate to respond to it fully and properly in that way. Okay, so let's take that question down from the website, from the screen. Thank you. And so, any questions from people in the meeting? Richard, I've got your hand up. Welcome, Richard.
Hello. Yeah, I think you can see me, to be honest. Yeah.
Yeah, I can see you now. I can see you now. Welcome.
Come in. Yeah, I was going to try to get into at the beginning of the meeting. I think I must have missed the meeting anyway. But when Kath was related to the crisis cafes, she said that it was going to be signed off under the do you think she could update me that? I mean, what is the is it just to have it in certain areas in Northern Waveney? And that's the first question.
Sure. I think, Richard, you couldn't get in when I gave an update in the action log, but I've got, and we've uploaded onto the website now, the situation with regard to the 5 crisis cafes, 3 of which that are currently open, 1 in Galston, 1 in Kings Lynn and 1 in Norwich, and the timetable for the cafes which will open, 1 in the north and 1 in the south, and they will both be sometime in April. So the information is available, but I'll email it to you as well, Richard.
Yes, you could. Yeah, I was going to reply to it. The other question is updating on the estates, and since West Suffolk is here, on the status of the hospital and the new hospital bill, in particular the campaign to actually get a commitment to get a rebuild for the Kings Lynn Hospital. I don't know if anybody can answer that.
So, your voice was dictated. It was to do with the rebuild of the King's.
I mean, it's to do with the hospital rebuild of West Suffolk, and to do with the RAC system, basically. All 3 hospitals are suffering from that. It's just that Kings Lynn is more affected by that than any of them, and there's been a campaign to have Kings Lynn included in the new build of hospitals, rather than just mitigation, really.
So you'd like to know if there's an update on that? Yep.
There's an update on it or not?
Yep. So who's able to respond to that, if we are able to now? John?
Yeah, just to say for now, my understanding is that there's no change in the position at the moment, but I believe that conversations are ongoing, Richard. So maybe it's something we can bring more of an update to a future meeting.
And another question is, to be honest, the first time I've heard about the care hotel. Perhaps Kath could actually go into a bit more how it's funded, how it's staffed, and where it actually is. I weren't too sure about it because obviously it's an issue with discharge and the patient flow and the lack of community care, really.
So, Kath, do you want to respond? I know it wasn't formally on the agenda, but I suppose it comes under system pressures and how we're responding to them, doesn't it?
Yeah, absolutely. So the first, I'm going to say I'm not going to disclose where it is. I think it is in the public domain, but we still made a commitment to the hotel that we would not yet, until all of the I's have been dotted and the T's have been crossed, not to name them, but it is in the Norwich area. How it's funded is through system finances, and we're funding it for a pilot of 3 months, and during which we will evaluate the impact and determine impact from a clinical perspective or outcomes perspective, but also value for money. And in terms of the model, there are 15 rooms for people to be discharged out of hospital. They will be people who could go home, but there's a shortage of domiciliary care, which is getting in the way of them being able to leave hospital. But the care provider that will be on site 24/7 is called Abbey Care, and they are an organisation with a proven track record of the care hotel model elsewhere in the country, and that includes them having already recruited staff, and they will come into Norfolk and Waveney rather than be recruited from within Norfolk and Waveney. So they bring an additional workforce to the system rather than us drawing on that pre-existing struggling workforce. So we're not robbing Peter to pay Paul, and it will be monitored, evaluated. I've got one of my senior, very experienced nurses that will be responsible for overseeing the quality, with my support, of course, and essentially it will be a test of concept, but for people who do not need to be in hospital and they do not have clinical needs that require them to be in hospital. I think that's a really important point, but I'll stop there. Thank you.
Thank you.
The last one is the mandating of staff, and I think it's a bad policy decision, which is now obviously government policy. But I assume that in fact, from what others were saying, that in fact the default is basically redeployment. But how far can that go in terms of maintaining staff's contract? And also, what is the breakdown? Do you know it's going to be the breakdown in terms of the acutes, where how it breaks down across Norfolk and Waveney in terms of those staff who for one reason or another refused to vaccinate?
So is there anything more we can add? Because obviously we discussed that already. Is there anything more we can add in terms of where we are now with that mandated vaccinations?
So do you want me to answer? Sorry,
yeah.
Chair. So we haven't got the breakdown at the moment. We're working through the data. We haven't got that level of information because each trust at an individual level is working through to, as I say, to offer additional support to people. So we'll have that as the next couple of weeks pass by. We will try and redeploy people as much as possible. But if you think, I suppose, the majority of our business is patient facing and is about patient care. Of course, we've got support services that are a lot of support services that don't that are not in a clinical area and may be suitable deployment. But again, we'll be working through that on an individual basis to see, you know, of those staff that absolutely won't take up the offer of vaccination, you know, where might their skills work. So we'll do that as far as possible, but we haven't got the data yet.
Okay, that's probably as far as we can go at the moment, and obviously we can bring an update to the next meeting when no doubt the policy will have changed slightly as well in terms of implementation, and perhaps including boosters.
Might be rolling back on that, to be honest. I'm not too sure, because I think it's a minefield really for everybody, to be honest. And I would have thought the NHS England would have said this is just not on, to be honest. Consistent pressure and everything like that, and staffing and everything. And then contracts of employment basically could lead to tribunals.
I certainly agree with you, Richard. It's very problematic in terms of implementing it, and it has created an extra complexity for us. But hopefully it'll pan out in a positive way that doesn't affect services.
Thank you.
Thank you for that. Any other questions? If not, I'll remind you that the next meeting, I was going to say the final meeting, but it sounds like it won't be the final meeting just yet in public. So the next meeting will be on the 22nd of March, and I think currently we should assume that it'll be done in the same way as now, although who knows, we may actually see each other physically before the CCG finishes. So I look forward to seeing you then. So I'm going to close the meeting, bearing in mind I make it exactly 5 o'clock. We have got a short second part to the meeting, and I suggest a 10-minute break to reconvene at 3:10 for that part. So can I thank you for your contributions, and wish everybody a safe and peaceful time until we next meet. Thank you.